on recording. So, hi, Ashley is the voice and little screen, and the one that keeps emailing you, I'm sure, over the course of the last month. But we have our name, organization, and where you're tuning in from in the chat storm. Calling in today from Omaha, which is turned into baseball town this last week. So, lots of baseball in town for us in Omaha. A few of the course logistics. This is pre-training webinar 2 of 2. And we're already on site in Denver next week, which is really close, like fast approaching. I feel like shipping out boxes today and just wrapping up all the things. The orientation packet is en route to you today, so that will be in the before you go email. It'll be an attachment. It's a PDF. You're welcome to print it. It'll be available in the Teams as well, but it should have everything you need to know about the course, any last questions, hopefully answered, all of those things. Um, Teams access was granted late last night. Sorry about that if it woke you up or pinged you and you were like, oh no. I was working away with my dog in the late hours. A before you go email will be sent to you after this webinar, so later this afternoon, just to get you as close as travel day as we can before you log off of work. Hopefully everything that you'll need to quickly access as you travel to Denver will be in that place. So hotel address, a couple things about like dress code, all of those things will be right there in place with the orientation packet. If it sparks any questions that you're still wondering about, please ask. If any changes need to be made to your lodging or travel, or as you're coming into Denver, if something happens and you're going to be a little late, delayed, my message phone number is in there, so you can send me a quick message and communicate with me that way. All right, that was a lot of information. There's more to come, but I want to hand it over to Dr. Mike Smith and give him as much time as I can. I hope I answered all the questions about housekeeping, but welcome, Mike.
Hello. Hello, everybody. Um, I also have some information to share, and it's kind of a lot, but hopefully, well, I think that it's stuff that you're familiar with. I'll share my screen here. Um, all right. How is everybody today? Doing well? In the mood to talk about statistics? I hope so. Um, you know, I'm a data person. I expect that most of us here are data people, though not everybody is, and though I don't understand it, like I get it, that not everybody is. But I'm so excited to be joining you all in Denver next week, where we're gonna get to have what I think of as like data summer camp. And it's a lot of fun and it's something that I look forward to and I'm so excited about it. I'm so glad that we're getting to do it. So the purpose of this webinar is just to provide some reminders and some underpinning, right? So the title of it is Statistical and Epidemiological Frameworks for Public Health Analysis. More accurate, though longer, title is probably things you probably know but may not have thought about in a while, so it might be good to have a refresher on, right? So that's the goal and the purpose here is to do a quick refresher on some of these things. And I'm gonna open the chat and slide it over onto another screen. So hopefully I can kind of keep up with it, but maybe not be too distracted by it. All right. So in terms of setting up, right, I want to acknowledge Dr. Deb Rosenberg and Dr. Kristen Rankin, who are professors at the University of Illinois at Chicago, who do a ton of really great applied epidemiology and biostats work in the maternal and child health field. They're awesome to work with. They've both worked with this course in the past. Um, so Deb Rosenberg was the the first faculty coordinator for this training course, and she was really truly wonderful, and she has continued to be involved with the training course in an ongoing way. Um, and then several years later, Kristen Rankin took over as the faculty coordinator for the training course, and was incredible. I think I mentioned in the last webinar that I was a participant in the training course also in Denver in 2012, and Kristen was the faculty coordinator at that time, and it was I learned so much from her and just thought the the world of her, and think the world of her work. Um, and a few years ago, like 7 years ago, 8 years ago now, I had the opportunity to become the faculty coordinator for this course, and it's a tremendous honor. And really, all I'm trying to do is make Deb Rosenberg and Kristen Rankin proud. So that's my extended acknowledgments. You'll see acknowledgments for them for a lot of stuff in this training course because they've been so essential in building it over the course of decades. All right, so uh, what we're going to try to do in this session is talk a little bit about what MCH EPIs do and where we fit in public health. I hope that you'll see the work that you do on a day-to-day basis reflected in some of those things. We'll also talk about some of the tools. We'll probably spend most of the time talking about some of the tools that MCH EPIs draw from. That includes a statistical framework that I'll also refer to as a sampling framework, and I'll explain why as we go through there, and then an epidemiologic framework, and then the big finish, and then we will go on with our days. All right, so kind of good getting into what MCH EPIs do and where we fit in public health. Of course, we're in this larger context of public health, where we have the essential services and core functions of public health, right? The core functions are assessment, assurance, and policy development, and we have within those a bunch of essential services. So that's what this kind of wheel picture is here, and then we have this I don't know, flowchart-ish picture here. This is the public health planning cycle, right? In order to plan, we do assessments. We look at capacities for implementing things. We look at strategies for implementing things. We develop plans, and then we do things. We don't just plan things in public health, right? We implement programs, procedures, policies, interventions, um, things to try to make uh, life better for the populations, the programs, the policies, things that we really care about, right? And then after we implement, we monitor, we do evaluation, and though the data that we generate through implementation, monitoring, and evaluation often feed back into an assessment for how to make these things better, right? So we have the context of the public health core functions and essential services and the context of the public health planning cycle. um, Something that Dr. Rosenberg and colleagues did several years ago was kind of apply this public health planning cycle to maternal and child health epidemiology to develop something that they call the MCH EPI effort. And that includes some things that we do on the planning side, right? We produce descriptive statistics on a wide variety of indicators to try to inform things like needs assessment and planning processes. We contribute to setting the MCH agenda. We support prioritization processes. We develop analysis plans. We select indicators. We set targets. And then some of the stuff that we do on the doing side of this model is we collect new data when it's appropriate. We monitor progress on priorities. Um, we monitor progress on selected indicators. We conduct in-depth analysis on a few key issues based on those monitoring efforts of a lot of things, right? We do descriptive statistics on a lot of things. We monitor off on a lot of things, and we do some in-depth study on a few priority topics. Often, sometimes we evaluate programs. We document processes. We try to assess the impact of programs, and then there are some things that we do on a routine basis often that are kind of in the middle of this planning doing loop, right? We disseminate and translate data. We interpret findings. Sometimes we do data visualizations and charts and things like that. Sometimes we give presentations and we try to explain things. We also promote data systems development. We conduct or promote data linkages. We try to expand access to data. We try to make sure that people are using the data that we are stewards of well, by doing things like filling data requests and things like that. So it's a really a pretty expansive role in this effort. And some of the things that maternal and child health epidemiologists do on a day-to-day basis, and certainly some things that I have done in my uh, different roles in my career, are things like data collection and descriptive analysis and analytic and inferential analyses and results interpretation and data translation and literature review and summary and evaluating programs and managing programs. Sometimes those programs are related to data and sometimes they're not. Supervising staff, advising or liaising or assisting program staff in getting their jobs done efficiently, collaborating with researchers, writing grant applications, designing studies, informing program development, informing policy development or policy implementation, monitoring trends and key outcomes, conducting needs assessments, presenting results to wide audiences, knowing all research and analysis techniques from memory without ever having to look into in textbooks or Google or AI or any of those things, right? We know it all, and we also know the details to all of the programs that we work with. We are proficient or expert in SAS, Stata, R, SPSS, Python, and other duties as assigned, right? I hope that you see some of your roles represented here and some of the things that you do on a day-to-day basis. You may do a lot of these things. I guess really what I'm trying to say is that the job of an MCH epidemiologist is a pretty easy job, where you kind of sit back and put your feet up, um, and you uh, go on really nice vacations and wait for the waves of money to come rolling in, right? Yes, so easy and relaxing. Definitely. So not an easy job, right? It's a complicated, sometimes complex job that requires a lot of skills. And we have these things that we learned in school and in grad school, that we apply in our jobs, and sometimes we are so busy kind of doing all of the different components of our roles that we don't think a lot about the statistical training and the epidemiologic training that we had in some cases. So really what we're trying to accomplish here, and the purpose of this webinar, is to try to get us kind of back in that frame of mind, because like I said, next week, like we're in summer camp, right? And we can really think about those things without hopefully without as many of the other components of our roles and some of the other distractions that we kind of have in our normal lives and in our normal um, job functions. So what I want to kind of go over here are some of the basics of analytic methods. Again, things that you know, but it's good to touch base on and maybe have a quick refresher on. So, and really what I'm going to be talking about are statistics and epidemiology, right? Things that we use to describe, to explain, or to predict the experience of a population. And we use statistical methods, right, where we are using statistics to to estimate things and talk about different average experiences. And sometimes we want to compare the average experiences of different populations, and we do things like testing hypotheses about whether this group experienced a larger rate or occurrence of an outcome compared to another group, right? So sometimes we call that hypothesis testing, and we use these statistical methods within the context usually of an epidemiologic framework, right? And so with epidemiology, we're looking at patterns of disease and well-being and other factors in populations, and that population part is really important, because usually we are working with or thinking about our data as a sample from a larger population. right? And from that sample, we're trying to estimate population characteristics, right? Like the mean birth weight of a population or the prevalence of low birth weight in a population. And sometimes we're trying to estimate relationships between two or more groups on those population characteristics, right? Do we have a greater rate of low birth weight among urban populations or rural populations? And how do we compare those, right? We can think about ratio measures to compare those or difference measures to compare those. Uh, and that leads us to hypothesis testing, right? When we want to test specific hypotheses about relationships between groups and different characteristics for these outcomes that we're interested in, right? And then that's the statistics that we use, right? We use measures of occurrence, like means, like proportions, percentages, rates. We use we summarize those sometimes and compare different groups with measures of association, like odds ratios and risk differences and things like that. And we do that within the context most often of an epidemiologic framework, right? And sometimes we're doing descriptive epidemiology where we're summarizing these things without an explicit hypothesis or set of hypotheses or a specific like causal structure or relationship in mind. And then sometimes we're doing this in an analytic epidemiology capacity where we are explicitly trying to test some of these hypotheses, right? About risk factors and their relationships to health outcomes or health services or policies or other health factors. And the if we are doing a lot of data work and epidemiologic work within our maternal and child health settings, we're probably calling on both these epidemiological uh, principles and frameworks and these statistical principles and frameworks to do the things that we do, right? We use both of these things for monitoring and surveillance, needs assessment, things like program development and evaluation, policy development, policy and program advocacy, epi research, health services research. In all of these things that we are doing, right, it's a lot of different kind of applications, but fundamentally, a lot of what we're trying to do across these different applications is we're trying to understand ourselves, right? What the relationships are, understand what the truth is in terms of these relationships, right? First, we need to understand it as the people with the data and the people analyzing the data. And second, we need to communicate that to somebody else, right? And you'll hear me talk about data communication a lot because that's something that I get really excited and passionate about. Um, but like if you use the the best data and the best methods and you apply them perfectly and all your assumptions are met and you get the exact right answer and you know it and you can't communicate that to anybody else, right? You can't communicate it to decision makers or to funders or to stakeholders who need that information, right? If you did everything perfect but you can't communicate it very well, then it's almost exactly useless, right? So in addition to us understanding, we also have to be able to communicate well. Um, and we can use these statistical tools, these epidemiological tools to to help us communicate in some cases, but in many cases they can be barriers to communication, right? Because you have training and literacy and expertise that some other people don't have, and maybe the people that you're trying to communicate to don't have. So we have to be really thoughtful, and engage a different set of skills for communication. Okay, we will talk more about communication, but really today what we're focusing on is this first one, like what tools do we use to understand and make sure that we have the right answers. Um, so earlier I mentioned populations, right? In public health and in maternal and child health, right? We're not dealing with patients or clients usually one-on-one at the individual level or the individual interaction level, right? We're focused on populations, and so we get a lot of data for a lot of different individuals or whatever our level of observation is, and we summarize that data, right? Because we're working at the population level, we have to summarize our data in a way that's effective for helping us understand the truth for this population. And so, in order to do that, we organize our data to facilitate summarization, right? We organize our data in data sets. Um, we use analysis methods that we select based on their ability to appropriately summarize the data, right? Like they have to meet certain criteria that we call assumptions in order to accurately give us insight into the truth of what we're trying to understand. And we also need to summarize our data and our measures in a way that contributes to our ability to communicate that information to the people that need to know it and need to understand it. So in terms of organizing our data, right, we typically have them in data sets. And where we have kind of the rows going down the data set or the table or the spreadsheet or the file, right? And often those rows are individuals, right? Data for individuals. Sometimes they're aggregates, right? It could be a county level data set where each row is a county, or it could be something smaller than the individual level, right? It could be like healthcare encounters, right? Where each row is a different encounter, and you can have multiple encounters for one individual, and then you have another individual that has multiple encounters, right? But that's really an encounter level data set, right? So we have different units of analysis or units of observation, and then going across the top in these columns, we have variables or attributes or characteristics or measures, and it usually looks something like this. Though a way that we might be more used to seeing it is like in a SAS data set, right? Like this, where we have different individuals with a unique ID number and a month of birth, right? And each individual has a month of birth and a state of occurrence and a state of residence and a maternal age. And maybe that maternal age was recoded into different categories and a number of prenatal care visits and a birth weight in grams, right? And so each of these individuals has values for each of these variables, right? That's the way that we organize our data so that we can analyze it. Um, and Next, I'm going to talk about some of the ways that we analyze it first. Before that, just to give me some scoping, Ashley's going to bring up a poll to ask how long has it been since you had a formal statistics course? And so we'll just look at the distribution of that. I think most folks have completed the poll now, so I'll go ahead and end it and show the results. So it looks like everybody has had a statistics course. So I was right in my alternate title, right? Things that you have that you know that you've learned before, uh, but maybe haven't thought about as much in a dedicated way in a while. Okay. And it looks like most folks, it's been 3 or more years ago since you had a. Oh, can you see these results? Or could you?
That was me. Sorry, I
Oh,
stopped it
okay.
right away.
Oh, all right. So yeah, so it looks like about a third of folks, it's been 5 years or more. A fifth of folks, it's been 2 years ago or fewer. All right, but everybody's had a statistics course. Wonderful. Um, I just want to make sure that I'm correct in that assumption, and that's not. It's an assumption that's based on your applications, so it's not an uninformed assumption. But it looks like that's good to go. All right. So when I talk about the statistical framework, really what I'm talking about is the sampling framework, right? Where we have a population that we're interested in, and we have a sample of representatives from that population, and we are conducting statistics based on that sample, right? And it's not everybody in the full population. The statistics that we're looking at are from this sample. Now, um, uh, you may be so I generally like all of the data analyses and things that we do, we kind of assume this sampling framework. We assume that our data are a sample taken from a larger population, and sometimes and that the true population parameters are unknown. And you may be saying to yourself, self, that's not always true, right? Much of public health data is actually population data, and there's no sampling. Like if we do um, census data, right, is supposed to be kind of everybody. Birth certificate data is supposed to be everybody, right? And some of these measures that we have are based on the populations and not a sample. So should we consider those the population parameters, or should we consider those the statistics from a sample? Are they the true values for the population, or are they estimates? Um, and and you may be asking yourself, why does that even matter? Why are we talking about this? Well, if it's a sample, then there are some distributional assumptions that we can make in order to compare to other populations and think about things in terms of a sample that we don't really have at the population level if it's the full population. But usually, even if we have population level data, we treat it like sample data. And there are um, uh, some reasons for that. But like if you calculate the infant mortality rate for a state, right, and it's based on all of the infant deaths and all of the live births reported for that state, and it should be the full population, given that, right, we know that the population of people that have babies from year to year changes and things fluctuate within that population in ways that if they're not random maybe, but they're very complicated in a way that we can't adequately model. So we typically treat those as sample data. And in practice, right, all health data is often and some would argue should be reported and analyzed as though it were sample data, and all summary measures should be reported as though they are statistics and not the population parameters. And that again is relevant because there is some theoretical underpinning of the statistical methods for this sampling framework. Um, that if we assume that it's a simple random sample of observations drawn from an infinite population, right, which of course is never true. It's never a simple random sample, really, or very rarely. And the population is obviously never infinite because we're bound by uh, space and time and things like that. So, but when we have large populations and we're drawing a simple random sample, we have uh, some axioms and theorems that really hold up very well, um, and that is pretty foundational for the way that we do a lot of statistics, right? Like basically every when we talk about things being normally distributed, like this is what we're assuming, a simple random sample from an infinite population, or close enough to that that it's not going to violate some of these assumptions. And when we consider data as a simple random sample, um, we acknowledge and we accept and we assume that our results will vary by chance from one sample of the population to another sample of the population. And if we're thinking about like infant mortality rates, that there will be some random by chance variation from year to year, just based on the variation of the quote unquote sample of people that deliver live births that year. And there's some shifting and some fluctuation in that we need to account for statistically if we want to understand whether or not the infant mortality rate is really going up or going down in a meaningful way, or if it's just kind of fluctuating within this kind of random uh, noise uh, interval that we would expect there to be some fluctuations. So one of the strengths and weaknesses of working with statistics is that the truth about a population can never be fully known, so exact answers are never really truly possible, right? You can never say, yeah, that we did this and it definitely led to an improvement in infant mortality. Like that's awesome. Let's all be excited. And you can also never say that we did this and it will definitely have we're doing this and it's definitely going to have an impact and the impact that we hope to see. Um, and if you expect it to and it doesn't have that impact, right, then you can say, "Oh, I knew it. There was always a chance our that our model was wrong," right? So it's kind of the a strength and weakness of this sampling framework is that you can never really know the truth, right? So you can never really uh, you you can never really assign credit and you can never really assign blame in a lot of ways because of this uncertainty. And that's frustrating for us sometimes when we are analyzing data, but it's often frustrating when we're trying to communicate data and what it means to other folks who need to make decisions with these results. So for that reason, it's important to try to account for this uncertainty or this inaccuracy, the sampling error or the random error in our data. And that's a really important part of statistical analysis, um, especially when we get into things like hypothesis testing and developing confidence intervals, right? And so we know that certain probability distributions describe how the values of a statistic will change if different samples of that infinite population are drawn over and over and over and over and over, right? That the mean values or the summary values from those large number of sample populations will follow a certain distribution. Those are called sampling distributions, and we can use some things that we know theoretically about those sampling distributions to inform um, our decision making from these statistics, right? And there's a group of distributions that come up a lot with the type of data that we typically work with, and it's a set of distributions that are in what's called the exponential family, right? And the normal distribution is the one that we use a whole lot. We also use a binomial distribution a whole lot. Like if we have dichotomous outcomes, um, and we also use things like Poisson, chi-square, exponential, F distributions. Really, all of these distributions are in the same family, the exponential family, because the they can be summarized by knowing two pieces of information, right? You need to know the mean and the variance in order to summarize what any of these distributions looks like, and then we can kind of jump back and forth between them in different ways. The normal distribution we hear about and talk about a lot, and it has this kind of special importance because with relatively large sample sizes, the distribution of those sample means, right? Again, if we're taking a bunch of samples from the same population and we are calculating the mean from each of those samples, right, the means will follow a normal distribution, right? That bell curve that we see a lot in statistics books and articles. Um, and those means will follow this normal distribution no matter what the original distribution that underlies the population um, comes from. So we use this sampling framework and this kind of special nature of the normal distribution and those other distributions in the exponential family to calculate uh, to inform our decisions about measures of occurrence. And so measures of occurrence are are the statistics that we often calculate to describe what happens on average in a population, right? So things like means, calculating proportions and percentages, calculating rates, right? Those are all measures of occurrence. How often does something occur in the data that we're looking at? They each describe that average experience from our sample that we're trying to use to make inferences about the average experience for the entire population. Right? Are you tracking? Does this make sense? Does this familiar?
Yes.
Yes. Okay. For at least one person.
Yes,
Okay. I've got
yes,
more people saying yes. Okay. Okay. I just wanted uh some assurance, familiar in the dusty corners of my brain. Yeah, good, good. So we're trying to pull it back more out of the dust and into the front, um, so that we can think about these things. But I also wanted to make sure that I'm not just talking to myself in my office and everybody's tuned out, right? Okay. So means we use to summarize continuous variables, and we assume that those means follow a normal distribution, right? Mean is the average, right? The arithmetic mean, the average, right? Where we add um, everything up and then divide by the total number of observations, right? We also have proportions, right? That can easily be converted by moving the decimal, converted into percentages, and those describe discrete variables, right? So we could have the mean birth weight for the population. We could have the proportion of the observations that were born low birth weight, and those proportions are assumed to follow a binomial distribution. Uh, some proportions are works better to consider them to be Poisson distributed if the numerator is very small compared to the denominator. That's really like if you're running a model, something that can make your model more stable. That's an aside that I couldn't resist putting in because like I said, I'm a data person, and so sometimes I can't help myself. Um, Rates are also based on discrete variables, like often dichotomous variables, right? Like they either happened or they didn't, and are typically said to follow a Poisson distribution. So we have these measures of occurrences, right? Like means and proportions and rates. And often we want to compare those measures of occurrence for different populations, right? And we can do that. Um, we can calculate the mean in one population and the mean in another population, and or we can calculate the proportion or the rate in one population and calculate the proportion or the rate in another population, and we can compare them in a couple of different ways. One is using the advanced statistical technique known as subtraction, right? And we can look at the difference measures. So we can subtract our means, right? Subtract one from the other and look at the difference. Subtract our proportions and look at the difference in those proportions. Sometimes that's called an attributable risk. Some uh, uh, If we're looking at the difference between two proportions, that may be a term that you're familiar with. Sometimes we want to compare the mean or the proportion to a standard, like say a healthy people objective or the average for the state or the average for the nation, right? We have some other standard. We're not comparing it to another subpopulation. We're comparing it for our jurisdiction to some external standard. We can do that with a difference often. Uh, the other way that we often compare uh, different means or proportions or rates is by another advanced statistical technique called division, right? We can subtract or we can divide. We can if we divide two rates, that's often called a rate ratio. If we divide two proportions, if they are risk proportions, that's called relative risk or a risk ratio. If we divide two proportions and they're really from cross-sectional data, so they're really the prevalence, sometimes we'll call that the prevalence ratio or the relative prevalence. We could also calculate odds ratios. Um, they're things that we use all the time. And where we're really just calculating these statistics and we're subtracting them or dividing them in different ways. And we use those probability distributions to calculate a range of values in which the true population, which is the what we expect to be the real population in the real uh, measure of association or measure of occurrence for the full population, right? Not just the sample, for the full population, we expect that to be within this range that we call a confidence interval, right? And we calculate the confidence interval either by uh, having a measure of occurrence or a measure of association, and then we add and subtract a critical value, right? The critical value comes from a probability distribution, like the normal distribution, right? So there's an element from the data, right? The kind of average estimate from the data, that's this measure of occurrence or this measure of association, plus a component from a distribution, right? That we are assuming that's this critical value, right? If you're using the normal distribution for a two-tailed 95% confidence interval, you may remember 1.96 being a commonly used critical value. And that's again based on assuming a normal distribution, and you want a 95% confidence interval for two tails. And then the other component is the standard error of the measure of association or the standard error of the measure of occurrence, right? And the standard error is basically a measure of how spread out the data in your data set are for this variable, right? How much variability is in there. So you have the components of this confidence interval being a measure of the average and a measure of the variability and something that you're assuming for the distribution of the population, right? Um, and these are the things that I said. Okay. Um, Typically, a narrow confidence interval indicates that we think that the population parameter is really pretty close to this estimate that we have. A wider confidence interval indicates that we're not as sure about what the population parameter really is. This is the estimate from the sample that we're looking at, but the population parameter really could be quite a bit different than that. So um, the way that we use this a lot of times is we're looking at the proportion of the population with health insurance coverage. And so we observe a sample proportion of 85% of the people in our sample have health insurance coverage. And we calculate a 95% confidence interval that ranges from 81% to 89%, right? What does this mean? I'm asking. Anybody want to venture a response? All right. So we're 95% confident that 81 to 89% of the population has health insurance coverage. Means that uh, that's within the confidence interval, so probably acceptable. Okay, yeah. So really, yeah, like we're kind of 95% certain that the true proportion of people with health insurance is somewhere between 81% and 89%. Um, and that's not exactly a correct interpretation of a confidence interval, but that's usually kind of the way that we frame it. Um, because the correct interpretation is really pretty cumbersome to say, and it doesn't mean much to most people. Like the real interpretation would be that if we took a bunch of samples from this population and we calculated the mean percent of people that had the mean percent of people that had health insurance, and we calculated a confidence interval around that. In 95% of those confidence intervals, the true rate for the population would be contained within that confidence interval, right? And like I said, that's a very cumbersome uh, explanation or definition to give even to people that know statistics and know what they're talking about. And so we typically kind of use this shortcut where we say, yeah, we're 95% sure that the true proportion is somewhere between 81% and 89%. And so, what if we're looking at a measure of association, right? We have our question is the proportion of rural residents with health insurance coverage different than the proportion of urban residents with health insurance coverage? And so we're looking at um, a proportion of people in urban settings where 87% of them have health insurance, right? And we have in rural settings, 84% have health insurance. And so that's a difference of 3 percentage points, right? So this is our measure of association, right? A 3 percentage point difference. And our confidence interval ranges from -1% to 7%. What does this mean? Well, when we're thinking about this, right, we have to think about what our null values are for our our measure of association, right? So we have a proportion from one population, right? And in our example, it's the urban population. We have a proportion from another population, and it's the rural population in that example. And let's just say that the proportion for both of these populations is equal, right? If they're equal and we take a difference, right, that difference is zero if they're really equal. If they're equal and we take a ratio, right, if we divide instead, then the result is one, right? So the the null value for a difference is zero. The null value for a one for a ratio, the null value for a ratio is one. So when we know that, like that's the number that we're really interested in is this null value contained in the confidence interval? And Fernanda, I think this is what you were thinking about is whether this null value is contained in the confidence interval. So if we're looking at difference measures, if the confidence interval includes zero, which again is the null value, right? Because zero point 0.2 minus zero point 0.2 is zero, um, then that means that our means or proportions or whatever we're comparing may be equal. They may not be equal, but they may be equal, right? If it contains that null value, sometimes we say that difference is not statistically significant, right? And when we say it's not statistically significant, we're not saying there's no difference. That's kind of like a statistical shoulder shrug where we're saying, is there a difference? Right? If the confidence interval does not include one, that means that those means or proportions are likely different. I mean, if the confidence interval does not include zero, which is the null value, then the means or proportions are likely different. Similarly for a ratio measure, except that null value is one, right? If the confidence interval includes one, that's our statistical shoulder shrug, right? We can't say that they're different. Um, if it does not include one, then they are likely different. So here in this situation, what's the null value that we're interested in, right? We're subtracting. What's the null value that we're interested in? Is it 0 or 1? Yeah, it's 0. And is that null value that we're interested in, is that within this confidence interval? Yeah, it is. So do we have a difference in the rate of insured population between urban and rural? Well, we can't say that we have a difference, right? We also can't really say that there's no difference. Um, but that's our statistical shoulder shrug, right? We cannot say that these are meaningfully or statistically different. And so, like I've tried to allude to there, confidence intervals only provide evidence for or against equality, and really only strong evidence against equality, right? Uh, if it includes that null value, it's more like a shoulder shrug, right? Like we don't know. Um, Statistical tests go a little bit beyond this, telling us the probability that a difference we see in our sample is due solely to chance. And that's what we call a p-value or a probability value. And then by convention, we we count p-values less than 0.05 as statistically significant. And we use these probability distributions to calculate test statistics and compare them to probability tables, right? If you remember taking a statistics class and you had to flip to the table in the back of the book to look at um, these comparisons to see if what you observed in the test statistic that you calculated was statistically significant, right? That's what we're doing. All right, so this sampling framework is what we use to calculate statistics to summarize sample data. And all of the statistics that we use are estimates, and therefore we assume that they are in error to one degree or another. And expressing the degree of error um, is very important for understanding and communicating how seriously we should think about this statistic, this measure of occurrence or measure of association, and what it means to us, right? And we express the degree of error through a confidence interval or a p-value, and we use that to try to make good informed decisions. So the basic components of any statistical analysis is we have a population parameter here that we're trying to estimate. We have a sample statistic that we calculate from the sample, right? Like a mean or a proportion. We have a sample size. That's how big our sample is. Um, we have we calculate the variance or the standard error, right? That's how spread out our data are. And we typically use a critical value from a probability distribution to that we make assumptions about that helps us think these things through. All right, that's my very quick, though it might not have seemed very quick, overview of the statistics that we often use. And we use those statistics within a larger epidemiologic framework, right? So like the statistics are kind of like on the inside and they're being applied within a larger epidemiologic framework to try to make decisions. And an epidemiologic framework we use for things like deciding what indicators are important to consider, right? What characteristics or demographic factors or risk factors or outcomes should we even be thinking about and calculating these statistics for in the first place? And then also to consider what data are available or what data will be available to measure these indicators, right? Do we have existing data sources or will we need to collect new data to be able to do this? Um, or do we have an existing data source, but is the quality bad, right? Sometimes we have a good data source that we can use for something, right? Like the chronic conditions from birth certificate data, right? They're there. There's a lot of evidence that shows um, that the quality of that data is maybe not so good, especially in some areas. Um, so the data exists. Can we access it? Do we feel like it's reliable and does it have high quality? And then if we use this epi framework, right, we use it to figure out what measures we need, where we're going to get it from, and then we use it to figure out what analysis methods we should use um, to try to answer the relevant questions or to summarize and describe the situation. So we think about how will the data be organized, what statistical approaches will be used. It is really important to have a systematic analysis plan, right, to effectively summarize data. Even in our MCH epi types of roles, even if we're not doing a causal analysis to try to answer a specific research question, right? Even if we're doing something more like summarizing across a bunch of different measures or a needs assessment or something like that, sometimes the complexity is in the volume of measures that we're looking at and not in the analytic approaches that we're taking, right? And even if we're not doing anything fancy analytically, we still need to be able to effectively summarize a lot of data, and we need a systematic plan in order to do that, right? That really facilitates understanding and it really facilitates communication. And so to develop a good systematic plan, we have to do some things that we recognize are important, like intellectually, but we don't always recognize that we need to do them in our jobs because we're so busy. It may seem impractical to do these things, but we have to do them if we want to do this well and do it efficiently. And those things are stop what we're doing. We need to have some quiet space and kind of a quiet mind so that we can focus on this because we need to think about what needs to be done, about the resources that we have, and we need to develop a plan. And it we're so busy that sometimes it's hard to give ourselves permission to stop, think, and plan because it feels like we're wasting time if we're not producing something, right? It feels like we're not being productive if we're not producing something. But if we are enabling ourselves to get to the end result that we want more quickly and more efficiently, and in a way that we can better communicate these results for impact, right? That's not a waste of time. That's a very good and efficient use of time if we stop and think and plan a little bit. And sometimes we have to remind ourselves of that, and we have to give ourselves permission to sit still for a little bit and to stop and think and plan. And so what does a plan look like? If we're doing a descriptive epi analysis, a plan might look like sitting down and thinking about the variables of interest that we need, and then thinking through, not with the data, just thinking through based on our subject matter expertise, the categories that we need to break these things down into in order to compare to other important standards or other findings from other places or previous work, or to categorize things based on our domain knowledge, right? We need to plan our univariate analyses, right? We need to uh, think about how we're going to assess for outliers, right? And what we're going to do about outliers. We need to think about what the distributions are. We need to plan our bivariate analyses. What do we want to compare and why? And what do we want to be able to say about it? And sometimes from those thinking about those univariate and bivariate analyses plans, we start to get ideas for how we want to present that data, and that's great. We should construct shells of potential tables and say, this is really what I'm trying to create. This is what I'm trying to generate from this data is something that looks like this, or maybe draw shells of potential charts or graphs, right? Defining the axes and showing what it might look like a trend over time for this category and a trend over time for this category. And these are the things I want to compare, right? Stopping and thinking about these things. And also, it's useful to articulate the potential narratives, right? If this is meaningfully or significantly higher than that, what does that mean? How are we going to talk about that? What if it's not? What if we can't tell a statistical difference between these? What does that mean? And how are we going to talk about it in that case? Setting that stuff out before you start analyses can help you think of a good study design. It can help you think more clearly about analysis methods because I don't know how many times I've worked with folks or myself and just gotten kind of bogged down in the data and like you kind of lose track of what was I trying to do in the first place because I've been looking at all of these different things in all these different ways and I've kind of lost the trail of the main point that I need to make or that I'm trying to make, right? Um, so stopping, thinking, planning, putting these things together beforehand can help keep us on track in the way that we want to be and need to be, right? And a lot of times we're looking across, yeah, analysis paralysis. A lot of times we're looking across different data sources, or we're looking at multiple versions of an indicator, and that can get us bogged down, right? We can be looking at the overall frequency of low birth weight births that occurred in our population. We could also look at the rate of low birth weight births. Um, we can look at the frequency or the rate or the proportion of low birth weight births um, among people who were, say, less than 25 and people who are older than 35 and in these different subpopulations. And we can look at urban versus rural, or we can look at in the city versus in the county, or we can look at in this part of the jurisdiction compared to that part of the jurisdiction, right? In these kind of, is there geographic variation? Is there a trend over time? And what about for this subpopulation? Is there a trend over time? And does it differ from this other subpopulation? In terms of low birth weight. And then sometimes we want to look at other related indicators that are not exactly the same, but like maybe preterm birth, right? It's not the same as low birth weight, but it's related to low birth weight. What about small for gestational age? That's also related, but not the same. And they can tell us different things. And we can start to think about like, are they telling us the same thing? Is the interpretation kind of converging on one thing, or is it different? And just with this one outcome, low birth weight, looking at it in all these different ways, we can get into some of this analysis paralysis, and that's not even really a complicated example, right? It's very easy to get into that situation if we don't have kind of a guiding plan as we set out. And then to further complicate things, our choices about which data to include in any analysis depend on the availability of data and the quality of data, right? I said that a few minutes ago, but if when we think about it, I'm sure we can all think of data that we wish we had that we don't have, right? For example, it could be very informative to report the incidence of child injury by type of injury and age, but we typically just don't have that data, right? Because you know some uh, some injuries result in an inpatient hospitalization. Some injuries result in a visit to urgent care. Some injuries result um, in going to the minute clinic or to a primary care provider or a pediatrician, or and some are handled at home, right? And we don't have data from all those locations. So sometimes the data that we have is maybe just for inpatient hospital stays, emergency department visits, or injuries that led to a death, right? And we can kind of get boxed in our thinking that because these are the only data sources that we have, that this is the rate of injuries, and really this is something other than that, right? Another example is if we're looking at prenatal care, right? I think we have kind of an understanding that um, that is a variation in the quality of prenatal care, right? That we often can't measure with things like birth certificate data. And so we measure instead the quantity of prenatal care, right? The number of visits. Was it kind of on the schedule that we expected to be on, or was it off the schedule? And if it was off the schedule, was it because it was too little, or was it because it was too much? And those could mean different things. But we get to where we're really just looking at the quantity of prenatal care, and we talk about that in terms of that describing the prenatal care experience. When that really describes part of the prenatal care experience. So we want to be careful that we don't let the data that's available or the high quality data that's available like limit our thinking and understanding about what this construct really is that we are really interested in, right? We need to recognize that okay, what I'm looking at here is the quantity of prenatal care, and I don't know anything about the quality, but that quality is really important, right? And because of that, because we don't have the data that we really want or that we really need, sometimes uh, in order to try to compensate for that and to try to like triangulate things and zero in, excuse me, on an understanding, like sometimes we'll present more data than we would like to because we need to use several less than optimal measures in an attempt to approximate the information contained in an indicator that we would really like to have, but is ultimately unavailable. Or sometimes we use poor quality data because we don't have high quality data. And this is just what we have, and it's what we'll use. And like I said, perhaps most problematic, like we kind of forget about what we're really interested in and just focus on what we have data for, right? Because we're constrained by the data that we have, right? And we are really we limit our thinking to just prenatal care quantity, and we stop thinking about prenatal care quality. Um, so as I said before, a lot of times like this just leads to a lot of data that we're looking at. And this is especially true in public health practice, and it's certainly true within maternal and child health epidemiologic practice, because we're often looking at data for a bunch of different population groups, and we're looking at data in a bunch of different domains. And so a lot of times the complexity of what we're doing is in the volume of the data that we're looking at and not in the analysis methods that we're using. And this can be especially true because a lot of times we're looking at data from a lot of different sources to look at data across all of these different population groups and all of these different content domains, right? And we've got a bunch of different data sources that maybe we use on a pretty regular basis. Um, and so a challenge that we often have that I stated at the very beginning of this is like it can be hard to develop a systematic plan, but I would argue that it is even harder to do this effectively without a systematic plan, right? That it's so easy to get lost in the volume of the data that we're often working with, that if we don't stop and think and plan for a few minutes, that we can get lost in that mountain of data and produce something that doesn't really help our understanding, and it doesn't really help us communicate very well to the people that we're trying to communicate to. So again, a plug for sitting down and thinking about some of these things before you even use R or Stata or SAT or whatever you use to analyze your data, right? Take a little bit of time and think about these things first. And if we do a good job of thinking about those things, and we develop um, a really good like descriptive epi plan, and we execute that descriptive epi plan very well, that process usually leads to the best analytic epi questions, right? That leads to the the best hypotheses and being able to ask questions about things that really matter. And for these analytic epi things, right, where we're trying to think about, does this cause this outcome? Does this exposure cause this outcome? Having well-crafted questions is really important. And sometimes uh, we develop the best questions by doing really good descriptive epi stuff. And then that enables us to develop a really good study design for answering this analytic epi question. This also leads us to asking consequential questions, right? Things that really matter, right? Last week, Ashley spent some time talking about asking consequential questions that can really impact the work that we do and the partners and the programs and the populations and the policies that we're working with. Okay. Uh, one more quick poll question and then we'll wrap up. All right. I think most folks have answered and we're looking at the results. Yeah, so a lot of us spend a lot of our time doing descriptive epi, data collection. We do some stakeholder engagement supervision, but not a whole lot. Some analytic epi, but not a whole lot, and some other things. Right? Awesome. So for doing these these epi comparisons, right? And using the statistical framework and the sampling framework kind of within this larger epi framework, right? We're often looking at 2 by 2 tables, right? To organize our data. And there are lots of reasons why we summarize things with 2 by 2 tables. And these are some of them. But basically, what we're often looking at is an exposure and an outcome. And I always put the exposure on this left side and the outcome across the top. There are some people that always do it the opposite way. That's fine. Like both ways are right. But this is the way that I always do it. And we can calculate proportion, or sometimes depending on the way the data is collected, and it's called a risk by doing A divided by N1, right? For the population that's exposed, that's the proportion that had the outcome among those who were exposed. We can also calculate the proportion that had the outcome among the population that's not exposed by dividing C by N2, right? And then we can take the difference between those, right? A divided by N1 minus C divided by N2, or we can uh, divide those, right? We can either divide them directly to get a relative risk or a relative prevalence, or a risk ratio or a prevalence ratio, right? Those mean the same thing typically. Or we can calculate an odds ratio, which is a little bit of a different calculation, and in I have I have fairly strong opinions about odds ratios. So I'll say this is unnecessarily complicated. Um, and I'll leave it at that for now, but I'm happy to talk more about odds ratios. I have a whole talk that I'd like to do sometimes called Down with the Odds Ratio. But that's a different thing, and I won't go on a tangent about it. Okay, so what does this look like with real data, right? So this is looking at as our main exposure, ACEs during childhood, adverse childhood experiences experienced during childhood. So some people reported that they had 0 to 3 ACEs. Actually, 87.7% of people reported that they experienced 0 to 3 ACEs. And 12.26 reported that they experienced 4 or more ACEs during childhood. And we are looking at whether people with 4 or more ACEs compared to people with 0 to 3 ACEs, if there was a difference in the number of poor mental health days that they self-reported, right? So comparing people that reported 5 or more than 5 poor mental health days per month to people that reported less than or equal to 5 poor mental health days per month. And we see here that among people with 4 or more ACEs, 32.7 report more than 5 poor mental health days per month. And among people with 0 to 3 ACEs, 14.54% report having more than 5 poor mental health days per month. And overall, it's 16.77% reported having more than 5 poor mental health days per month. Right. And if we want to compare this group with 4 or more ACEs to this group with 0 to 3 ACEs, we want to compare this 32.7 to this 14.5, right? And we can compare those by dividing them and getting this ratio, right? 32.7 divided by 14.5. That gives us a prevalence ratio of 2.25. We can subtract them, 32.7 minus 14.5, and that gives us a prevalence difference of 18.17. Or we can calculate an odds ratio, right? Which this odds ratio calculation gives us 2.86, which is again not quite the same as this prevalence ratio, and it doesn't exactly mean the same thing, but it kind of means the same thing, but the calculation is more complicated. So again, I would recommend just doing it this way, right? For the purposes of easier communication, because and better understanding, because that's really often what we are looking for, right? This prevalence ratio or this prevalence difference, right? So that's how we're often looking at the data that we have in an applied setting, right? Okay, big finish time. So I've tried to make clear, right? There are a couple essential things for effect that I think are important for effective MCH practice, right? We have to get a good understanding as the EPIs who are looking at the data and analyzing the data and have access to the data, right? We have to have a good understanding of what the results are and what the results mean. And are the results reliable, right? Do we feel like this is a good estimate of truth? Um, and we have to be able to get that understanding ourselves, and then we have to be able to communicate that understanding to other people in a way that is clear and in some cases in a way that is compelling, right? And we want it to be understandable, and uh, we want it to carry the appropriate amount of weight, right? So scientific rigor is a requirement for understanding, regardless of the audience that we're communicating with. We have to do it the right way to be able to get an understanding. But just because we use advanced statistical methods, or we use or we are using p-values and confidence intervals and standard errors and things like that, that doesn't mean that our communication has to be complicated, right? And a well-planned epi analysis will help us apply the right statistical methods and craft a meaningful narrative, right? So that's really what I wanted to try to accomplish today was one, to try to pull some of those things about standard errors and null values and critical values and confidence intervals um, and epi frameworks, right? Kind of from the dusty parts of our brains, right, more out into the retrievable places in our brains. And then the other thing that really wanted to try to talk about was the importance of thinking about communication and the importance of planning to facilitate good communication. So again, those are the two big things I wanted to accomplish. And this is a picture of Claire and Tumbleweed. And I'll let you try to guess which one is which. And I will stop there and we can talk about any questions or any comments anybody wants to make, if anybody wants to add anything. And I do see one question in the chat, an example epi plan that we could use as a template. I mean, I put the example that I would use in the slides, right? Like this is what I would do. And this is what I would recommend as kind of a descriptive epi plan. Um, and then during the course, we'll talk about things that during the course next week while we're in Denver, talk about things that might be good components of a more like inferential statistics, analytic epi plan where we're trying to answer a specific research question. So I maybe you want something more concrete than that, and I'm happy to chat more. All right. Other questions, other comments, other thoughts? You want to see Tumbleweed and Claire again? All right. Was this useful?
Very useful.
Yeah.
Okay. Cool. I hope it was useful, and um it was either very clear and nobody has questions, or it was useful in a more abstract way and not very clear. All right, if there are no other comments and questions. Oh, somebody says, I love the name Tumbleweed. Yeah, does anybody else have a child named Tumbleweed? Um, I'm joking. That's obviously the name of the donkey, not the child. Um, All right. So if there's nothing else, thank you so much for being here. I'm so excited to be in Denver. I can't wait to get there and to get into the training course. Safe travels, everybody, and I will see you next week outside of your um, empty Zoom boxes. Right? All right.
Thanks a lot.
Yeah,
Thanks.
thanks everyone. More in your inbox soon.